Yeah. All right, welcome to Deuk Spine Institute. I'm Dr. Deuk Majin. Our patient here travels to us from Georgia. We were doing mostly islands today. We had Puerto Rico. We had Trinidad, thank you. And we had a patient from Seattle, which could be an island, but also Korea, which is definitely an island. And then our patient from Georgia. So our Georgia patient has broken the island chain. Okay, are we ready? He has 3 discs that are problematic. L2, 3, 3, 4, 4, 5 on the right side. And we recommended treatment on the right side. Have we numbed?
Yeah.
All right, I can kind of feel it. So we're going to go in and try to fix all 3 with 1 incision. And hopefully we can do that with some luck. These discs are causing back pain. I think they're also affecting his leg. Shot? All right, so there's 5-1, there's 4-5, 3-4, 2-3. So I could probably be a little bit lower. I'm still going to numb up while I'm here. And why are we doing surgery? He has chronic back pain. He wants to get rid of it. When you have chronic back pain, there truly is only one way to get rid of it, and that is to, first of all, identify the source of pain. Man, we're way off. So identifying the source of pain means figuring out where it's coming from. And in most patients, it's going to be the disc. What is the disc? The disc is a big cushion between the bones, and the disc itself is normally painless. Shot? But when you are you lined up at 4-5? Shot? That's the first one I'm doing, so I'd like to try to get the 4-5 lined up as best possible. As I was saying, the disc is the most common cause of chronic back pain. And I think you're off on orbit just a little bit. You see the 2 facets at 5? As I'm talking to you, I'm trying to work with Jordan. Let's fix the orbit a little bit. That's better. Just stay there. Just stay there. I think that's the best we're going to get. Shot. Shot. All right, give me an AP. On the side view with the x-ray, it's looking good. We're in good position. On the front view, we're in excellent position as well. I'm starting with the L4-5 disc. Then I'm going to next do the L3-4 and then the L2-3. You can see the L5-S1 disc below. Shot. If you have questions, feel free to ask us, and I'll do my best to answer them for you. Unfortunately, most surgeons don't know how to do this kind of surgery. Unfortunate for the patient, that is. Unfortunate for the surgeon. And most spine surgeons end up recommending and offering their patients far more invasive treatments like fusions, laminectomies, microdiscectomies. And I used to perform a lot of those types of surgery until I discovered the endoscopic approach, which is far safer for the patient with a better outcome for the patient. Endoscopic surgery was first performed in the lumbar spine, where we are now, by Dr. Parvez Kamben. He's an Iranian orthopedic surgeon who taught at the university in Pittsburgh, and he pioneered this particular transforaminal approach. We call it AP, back in the late 80s, early 90s. He had his first set of trainees or fellows, lateral, and they learned how to do the surgery from him. Now, back then, since he was the first one to really do it, the equipment was not really developed that well, and the instruments he used was not really refined to give the best possible results. Over the years, some of his students have gone on to improve on the design of the instruments and the technique. And one of his students, probably his greatest student, was Dr. Anthony Young. And Dr. Anthony Young was one of my teachers. So I'm sort of the second generation. I think you'd call it second generation, right? Endoscopic surgeon. I learned from several surgeons, one of them being Dr. Young. We're ready for him to be awake. And of course, I've told you before, Dr. Sang-Ho Lee from Korea, Dr. Gun Choi,
How you doing, my friend? You okay?
and Dr. Sebastian Royton, Dr. King from England. All these surgeons were the pioneers, the first of their kind to do these types of procedures. Not what I'm doing, but this transforaminal approach. You see, every spine surgeon is taught to approach the spine from the middle. That's what I was taught. We go from here, we peel the muscle off the spine, we create scar tissue, and then we drill holes in the bones and ligaments. How long have you had back pain?
How many years back pain? How many? 9? What'd you say?
How many years has he had back pain?
I think it's 12. Okay.
12. So he's had pain for 12 years. He's from Georgia, and we're going to fix that today. Are you comfortable?
You said yes.
All right. Are you having any pain right now?
No.
Huh? No? Are you comfy? Yeah? Can you understand me?
Can you hear Dr. Deuk? He said yeah. He's a little sleepy.
All right, just give him another second or two. We have no rush. All right. You comfortable?
Yes.
How bad is that pain right there on a scale of 1 to 10?
10.
10. All right. Is that where you get pain? Yeah?
Yeah, he did.
All right. So we tested the L2-3 first. You can see it on the x-ray. Jordan, show us the giant tear. That is definitely painful. You could hear him go, ah. Right? I didn't tell him I was injecting. Is it better now? All right. You having any pain? No? How bad is that? 10? All right. Is that where you get pain typically?
Yes, sir.
All right. 10 over 10. So that was the next disc, which we're fixing, which is 3-4. You can see the giant tear where Jordan's arrow is. That's where the pain comes from. Is it better? All right. I'm sorry. I hate doing this, but it's good to know for sure that we're fixing the right thing. How bad is that on a scale of 1 to 10? Huh? 10? 11.
11.
All right, 11 out of 10. So we can put him to sleep. You're going to go nighty-night. When you wake up, your pain will be gone. All right. Let's go ahead and Henry, let's show the audience why is it that these discs can become so painful. All right, welcome back. We are now entering the tear in the disc at L4-5. The L4-5, remember that was the last one I tested. It was 11 out of 10 pain. So 10 out of 10 is the worst pain in the world you can ever experience. He said it was more than a 10, it was an 11. And I believe it, okay? So we're gonna fix this one first, not because it's the most painful, because it's just the one we're gonna fix first. No particular order. We have 3 to fix, so we'll just get on with it. If you have questions, ask us. But in the meantime, we're gonna show you one more video. This is how we fix these problems. Are you doing 2024?
For the next one I will, yes.
All right, let's do it.
Copy that.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
All right, welcome back. You can see the procedure we're performing is one that uses the endoscope and laser to basically go inside the back of the disc to where the tear is that causes pain and to repair that area using the laser. The endoscope allows us to see what needs to be done, so the surgeon can guide the laser appropriately and not just poke around hoping to find the area that needs to be fixed, but actually find it using the endoscope. Endoscopic spine surgery is the future of all spine surgery. It's less invasive, it's safer, it's less bleeding, less complications than open surgery. Now, if there's a surgeon who doesn't know how to use the endoscope, then they're going to recommend open surgery on you because they don't know how to do endoscopic. But what you really should ask yourself is, what's best for me? What's best for you is to have the best surgery that can be done to fix your problem. And sometimes that means you have to find a surgeon who can offer you that. That surgeon may not be where you live. This patient traveled from Georgia. The last patient traveled from Puerto Rico. The patient before that patient traveled from Seattle, Washington, and Korea. And the patient before that patient traveled from Trinidad. All of them coming to Deuk Spine for one purpose, because they couldn't get this surgery done, or the surgery they needed done, where they live. And we offered it here at Deuk Spine. All right, any questions?
At this moment, no current questions.
Henry, we got something must be wrong with the broadcast. I don't know. Do you think?
I believe it was just a long period of time of just being away and then just slowly, gradually coming back. But I believe
And you had all the surgeries posted?
Yep, all the surgeries, everything, and so we do have a crowd, but not as much as we usually do.
It's a shame that social media does not publicize what we're doing more.
Yeah.
So that more people could benefit from learning. This is a real live surgery they can watch, not some fabricated garbage that some of these surgeons put together.
Yeah.
Where they cut out all the bad stuff and just show you what they want you to see. You're seeing the whole surgery here, good and bad.
And like YouTube is also meant for a place of education, and
they're not really promoting or educating. We've been streaming for 10 years on YouTube, and YouTube acts as though we don't even exist.
It really hurts, and I do everything I can to exploit us as much as we can, but at the same time, I mean, like...
No, they want money. They want us to promote, pay for people to be aware of what we're doing. But I don't want to pay because, number one, we don't have it in the budget. We're already spending a lot of money broadcasting for the cameras, your salaries, and all the equipment we had to buy and spend, and all the internet service and storage service and servers and everything else we have to pay for, which we don't get compensated for. All that money spent to educate people. The least YouTube could do is make people with back problems aware of it. It's just a shame.
Honestly.
And yet people have so much faith in social media. Social media does not have your interest at heart, folks.
Nope. Not one bit.
It's all about making money and basically exploiting people to make money.
Exactly. Literally can't say it better. It's just sad.
Oh, it's really sad.
Yeah.
Nothing wrong with making money, but when you have to exploit people to make... You don't need industry support. Social media, you know, you see all these videos like women with their tits hanging out and they have 10 million views. It's like, okay, how many women's tits can we possibly look at? And there's 10 million views, right? Well, how about actually somebody getting their back fixed, giving it 1,000 views? I mean, is that really that hard?
Like when it comes to just organic research, I mean, YouTube, Google, Apple, like all the major tech companies, I mean, like they don't focus on that or organic stuff because it doesn't sell. But even though organic is what we want, what the audience wants, what the demographic wants, but like we just get this garbage of just content that doesn't matter to us. It wastes our time just watching it. But when it comes to this kind of stuff, that's actually like
well,
very
here's the thing.
Informative.
We know from our patients that they love to watch these videos.
Yes.
Okay? We know that. They love it. That's what guides them to us to get cured.
Of course.
So if there's people with back problems that want this, they want this service, then why are there not more of them watching? So it's not that there's not a market for it. There is a market for it. They're out there.
Yes.
And Google knows who they are. They just won't show them our videos intentionally because they want us to say, oh, we don't have enough viewers. Let's pay money to promote the video. Facebook's the same way.
Exactly.
You know, they're all guilty of basically not showing content to their viewers unless it's promoted by the person developing the content.
You can definitely perceive it as like, scratch my back, I'll scratch yours. But in reality, it's just like, hey, pay us a bunch of money and
No,
there's
we're
an off
scratching
chance.
their back. We're giving them content. We're not charging them.
I know, but it's like saying that like we give them content, but then they could do whatever to promote it and like just exploit it to everybody. But like they choose not to because it's like it's not what's in the now, what's not trending, and like
Look,
it upsets me.
If we're selling Bacardi rum, right, we should be paying them to show people Bacardi rum videos, right?
Of course, yes. 100%.
But we're not selling Bacardi rum. We're not selling something that kills brain cells, creates addicts, and causes car accidents that kill people.
No.
And does all kinds of other bad things, right?
No, we are not.
We're actually trying to show a way to get out of pain, to help society get better.
Exactly.
That, it's not like, it's completely different than most advertising, in my mind. We're not selling condos or airline tickets, to go to the whatever, travel. We're really showing people how to get out of pain. They should do their part to help those people with medical conditions that need help. They need access to care. It's really more medical.
Yeah. Honestly.
All right. How are we doing on irrigation, ladies? Just about done with our first disc. So far, the patient's doing really well from a surgical standpoint. How are they doing from an anesthesia standpoint, Dr. B? Remember, folks, this was the ultra painful disc.
We do have a comment.
Sure.
This is coming from Larry on YouTube,
Hello, Larry.
saying, I certainly appreciate your education for me. I have convinced a friend of mine to come to your place. I believe he is coming next month. I'm also in need of your service. I am 69 years old. Actually, I have introduced your service to 2 friends. Both are planning to come.
You're the best, Larry. Seriously. You care about your friends. You want them to have a treatment that works, that's safe. That's, my mind, the definition of a good friend. Looking after somebody who's your friend. Yeah. I appreciate it. All right. We're just about done here. You can see the laser there. I apologize that the view is not great. There's a little bit of oozing of blood from a vein. I mean, we're talking about a minuscule amount, so don't get worried. But you can see the laser fiber, and that glass fiber is 1 millimeter wide, just to give you a perspective on how big everything is here. The fiber is 1 millimeter. 1 millimeter. This was that very painful disc, the right, the L4-5, Luis. We've got about a minute left on this one. There's a lot of talking going on. What's going on, guys? Everything okay? I don't like hearing so much in my ear. I like to be able to focus and talk. Let's keep it down, please. Unless there's something I need to know about. All right. We are at the back of the disc. You can see the epidural fat. There's the vein right there. You see that? Look how the laser can cauterize it. See the tiny vein right there? Pretty
Yes,
cool,
we do.
huh? If I shut off the irrigation, you'll see it even better. It's still leaking a little bit. Watch. I'll show you. I'll shut off the irrigation, then you can see it. You see that? Like a little fire hose pumping out blood.
Yes, we do.
Now, of course, it looks really bad, right? Like, oh my God, there's bleeding. But the reality is every surgery has some bleeding. That's a highly magnified. Remember, this fiber is 1 millimeter. So that little vessel there is about 2/10 of a millimeter. It's tiny. And the amount of blood that was coming out is minuscule. Like if you poke your finger to get your sugar checked, that's about how much blood comes out. All right, any questions?
Yes, we have a question from Larry, once more on YouTube. And they ask, my situation is rather complicated. How do I start the conversation with you all? I'm in New Mexico.
Well, Larry, the first thing you need to do, and we highly recommend this as the first step for anybody that wants answers, like what's wrong with me and how do I get fixed? Okay, and that is to do our free MRI review. It doesn't matter where you are, it's free. And we don't charge, we don't sell your information. We literally just try to help you. You get about 10 minutes of my time. I know it doesn't seem like a lot, and it isn't. But it's enough time usually for me to figure out what's wrong and to tell you what's wrong and then give you a way to get out of pain. Now, I'll be honest with you. Sometimes people think that I need to hear all kinds of stuff during these meetings, but I don't. I just need very specific information, which I'll tell you during the meeting what I need to know. And I can diagnose you in 10 minutes what's wrong in about 90% of the patients I see. Now, about 10% of the patients, we need a few additional tests, or they have problems that we can't see because they're not having the problem at that moment that we're doing the Zoom meeting. All right, remember to diagnose a pain source. Let me have one more irrigation. To diagnose a pain source, you got to know where the pain's coming from. I need the patient to be able to say, my pain's here, or my pain's here, or my pain's here. Because all three of those spots are totally different sources, right? One of them may be your SI joint, the other one may be a piriformis muscle, and the other one may be something else, like your facet. So it's very important that you guys are able to show me on that Zoom meeting where your pain's coming from. That's the first and foremost thing. A lot of people think that I need to hear like how long you had the pain and when it started and what positions make it worse. I don't need to hear any of that. None of that actually makes a difference at all. What matters is what does the MRI show and what does the patient say as far as where the pain is coming from. And then there's a physical exam that I do, and I'm going to have you push on certain areas of your back to check for tenderness. And if you have tender spots, I want to know where they are. So that's really what I need in that 10-minute call. I'll give you a diagnosis and then tell you what I recommend for treatment. Hold. Okay. Once you're given a treatment recommendation, you can decide if you want to come and get it done or not. Or you could say, you know what, I can't make it out there, but what would be the second best treatment? And I'll tell you, all right, do a fusion or something. I'll tell you whatever it is. In my opinion, what would be the second best treatment? Are they different needles?
No. It's probably these two. It's a little bit complex inside. The inner tube is
I see. All right. We're going to work on disc number 2. So Larry, that's what I recommend. Do your free review with me. get a diagnosis, and then decide if you want me to fix you or not. Okay, folks, we are going to start the number 3-4 disc. This was a 10/10 pain. Now remember, when I inject the disc, it can be a 0, it can be a 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 is the worst pain that you can possibly have in your life. And a 10/10 is the worst pain that you could possibly have in your life. When people say 11, it means that that's more pain than they've ever had in their life. Okay? So that's how painful discs can be. It's amazing, isn't it? Such a tiny little thing can be so painful. And for those of you who don't understand that, think about an ingrown toenail. Have you ever had an ingrown toenail? No? Nobody's ever had an ingrown toenail? Louise has. She hasn't.
I know a person that has.
Oh man, toenails, like if your toenail gets stuck, the corner of it gets stuck under your cuticle and it grows in there, man, it turns red and tender, man. You just touch it and you're going to howl in pain. And that thing is small. It's like 2 millimeters, you know, it's not big at all. Horribly painful. That's what an ingrown toenail is. And a herniated disc is the same way. It's a very small area that is exquisitely painful because of inflammation. All right. Any questions?
We have a comment and a question. This comment coming from Billy54 on YouTube,
Hello, Billy54. Welcome to our stream.
saying, "Hi, Dr. Deuk. A few months ago, I mailed you a copy of Technique brochure by Dr. Robert Williams, who pioneered a less invasive technique for disc surgery in the 70s. And I also met Dr. Roden. Like you, he was a pioneer who fought against the practice of doing open laminectomies. Keep up your great work."
Thank you so much. Yes, I remember receiving your article and reading it. Thank you. We will keep it up, my friend.
This next one is a question from Teresa on Facebook,
Hello, Teresa. Welcome.
asking, "Hello, Dr. Deuk. Can this procedure be done on multi-level spondylitic myelopathy from C3 to C7?
Teresa, great question. So, to summarize Teresa's question, she's asking, can we do the endoscopic laser surgery for multiple levels in the neck from C3, 4, 4, 5, 5, 6, 6, 7, 4 levels for spondylitic myelopathy? The answer is yes, we can. You can avoid having a major fusion and laminectomy or discectomy. However, to give you a 100% answer, I need to see your MRI. Okay? If your spondylitic myelopathy is all bone spur, huge calcified spurs, the answer is you don't want this surgery. It won't work. But I need to see the MRI first. But to answer your question in general, yes, it can. I recommend you do an MRI review, Teresa. They're free. It's done virtually. You can do it from the comfort of your own home. They're free to everybody that wants it, all around the world. It doesn't matter what insurance you have. It doesn't matter where you live. All that matters is that you want answers. You have an MRI already, and you can get on the internet and do a call with me, a Zoom call, and then I can tell you what I think. Okay? All right, we're almost done with this disc, and we got one more to go. Remember, this patient, we tested these 3 discs before we started the laser. At the beginning, you can rewind it if you want. And 2 of the discs were 10 out of 10 pain. 1 was 11 out of 10. This is a 10 out of 10 pain. See the blue dye? It's staining the degenerated nuclear material. The white stuff is scar tissue. The red there on the side is blood. And there was some inflammatory tissue as well. This gold stuff is calcium. When the laser energy hits calcium, it oxidizes it, turns it a gold color. That calcium is there. It's kind of like a bone spur or calcification of the disc. Calcification of the disc only happens during injuries to the disc. So when you see calcium like this, it means the disc is injured. It's not a normal part of a normal disc to have calcium in the wall of the disc. Not to this extent. So this is very abnormal, and we see it on pretty much every single patient we do the surgery on. Was that you?
Yeah, I'm sorry. Just adjusting the brachial plexus.
Okay. Thank you. Any other questions, Henry?
At this moment, no current questions.
Anybody wants a great movie to watch? I rewatched Chariots of Fire. Has anybody seen that one? Great movie. Chariots of Fire.
My mom loves that movie. I have not seen it yet, though.
Right now.
Huh?
I'm watching this series on, it's called Eric.
Eric?
Yeah.
Huh.
It's pretty good on Netflix.
Netflix series Eric.
Yeah.
Interesting. What's it about?
It's about a puppeteer in New York City back in the late 70s who, his son gets abducted.
Abducted.
Abducted. His son's like 11.
Oh, yeah, I've seen a clip of
He
that.
goes to work every day with his dad. And one of the days he gets abducted on a busy city street. And I'm kind of that's what I'm up to right now.
Really?
It's a pretty good, interesting show.
And it's called Eric.
Eric.
It's so funny you say that. I just saw on TV there's a TV show called The Changeling.
What?
Changeling. The Changeling. Anybody familiar with that story?
Is that a ghost movie or?
No. The Changeling is actually true story about children that were abducted in Los Angeles area back in the 40s or 50s. And the movie was made with, what's her name? Angelina Jolie. This is about,
Oh yeah, she's the mom of one of the children.
she's the mother of one of the kids that got abducted. And it was really bad. It was some horrible person capturing children and doing bad things to them on a farm. Anyway, she of course discovered what was going on. The Changeling. But I was surprised to see they made a TV show out of it. Very surprised.
The TV show is set in an alternate New York City rather than in L.A.
Interesting.
Yes.
I'm pretty sure it was New York City for the Changeling for Jolie. I mean, L.A.
No,
for
you're
the-
right. Yeah, L.A. for the movie, New York for the TV show.
I wonder if there were, I guess there's a lot of these bad people. Horrible, horrible people. I mean, to take a child's life is like the worst thing in the world you could possibly do. Just pure evil. All right, just about done. I got 30 seconds to a minute left here, and then we're going to go on to our last disc. This one is going really well. By the way, notice when I'm finished how the tear in the annulus is actually not closed, but about 3 millimeters, whereas when we start it's about 6 millimeters, 7 millimeters. Let me have a grabber. Just going to make sure I'm not leaving anything here. Look at the fat right there. See the yellow fat? That is fat around the nerve. Nerves like lots of energy. They're, let me just see. Yeah. Nerves need energy. And they use fat. Fat is a storage form of energy. We all know that. It's a very efficient way to store energy in the body. Remember, our bodies are 70% water. So having fat is nice because everybody knows fat is hydrophobic, hates water from your high school chemistry class, and therefore fat does not require water for storage. If fat required water for storage, we would be about 3 times heavier than we are right now. Humans would not weigh 150 pounds. We would weigh 350 pounds, 400 pounds. Because you have a lot more water storing that energy, or we just have less energy stored. Kind of interesting. For anybody young out there aspiring to be a doctor, I recommend biochemistry as a major. Biochemistry, cell biology gives you great insight into life, the basis of life. All of life depends on biochemical processes that occur within the cellular domain. So I was fortunate enough to get major in biochemistry and cell biology, and then major also in chemistry. So it gives me an insight into how things work, which has made me a better doctor and marine biologist. Okay.
Your last patient has no pain.
Good. Send him out.
He's standing and twisting, has no pain.
Good. Our last patient we did has no pain. That was the Puerto Rican patient. He's going home with 0 pain. Why don't you let him go? I don't need to see him. I already saw him actually.
I'll let them know.
Yeah.
Yeah, as soon as they just got him up, we're going to be moving him around here a little bit.
All right, we got one more disc to do and we'll be done. And
You'll let him know, Deuk?
Yes,
huh?
I will.
Yeah, let them know, please. They don't need to keep them.
No, I'll let them know.
Yeah, thank you. So this is the final disc. It's 2-3. It's the top disc. This was the 10 out of 10 pain. Shot. You know, where you inject this medicine that's a numbing medicine in the fascia and how much you inject is important. Because if you put too much, hold on. If you put too much of the medicine, or you put in the wrong place, the patient's nerve can be numb and they won't be able to walk afterwards.
He's doing okay?
Are you asking me?
Yeah.
Mm-hmm. He's doing great. This is the last one. We'll be done in 10 minutes.
Thank
Yeah. But his surgery,
you. We're going to be in the other room for the last one. Yes.
fine.
They're all set together.
So no broadcast. Yeah, that's fine. We don't need to. It's a single level DPR cervical. Nobody wants to watch that anyway. Just kidding. But the last patient for today, which you guys won't be seeing because we're doing her surgery in another room, she apparently doesn't want to be broadcasted. And it's a quick surgery anyway, so we would literally start the stream and then end the stream within a minute. Point is, she had surgery on her brain, and she's probably going to, unfortunately, have to come back after this and get a fusion done at C1, C2. I hope to God she doesn't, because I don't want to do that surgery. I mean, it's a very invasive and risky surgery for the patient. But she's in so much pain, and she's been in pain for over 10 years now in her neck.
Doing that next week?
I'm doing the DPR hoping that that fixes everything. But we'll have to wait and see. But I have a very bad feeling it's not going to. I mean, I told her that. I said, I think you're having C1, C2 pain and you're going to need a fusion, but I think we should do the, how did that move? I think we should do the DPR just to make sure that you need the fusion, if you need it. A lot of times as surgeons, we always try a less invasive treatment that has a very high chance of working. I wouldn't do a less invasive treatment that doesn't have a chance of working. That just doesn't make sense. But it's okay to do a less invasive treatment that has a high chance of working, like 50% or higher, to avoid a more invasive and dangerous procedure for a patient. I think that's a reasonable compromise. All right. Lots of little pieces of herniation. You see them floating around. Hold on. Man, there's a lot of fragments. You keep taking out and more fill in. So what are these herniations? They're pieces of nucleus pulposus. Look it up. Everyone knows what the nucleus pulposus is. It's called the jelly in the center of the disc. And if you think about a disc being like a donut, the donut, the flour is on the outside, holds the jelly in. And if you get a hole in the flour, you can squeeze the jelly out, right? We've all squeezed the jelly donut and squeezed the jelly out through that little hole. We've all done that. I prefer lemon. What's everybody's favorite donut? Let's talk about donuts for a minute. Bavarian cream? You? No way. To have two people with the same favorite? I know they're good, but I'm saying favorite. Which one? Chocolate glazed? Like old fashioned?
Yeah, it was National Free Donut Day last week.
Oh, come on and get one.
Because there are no free donuts nationally.
You could go to Krispy Kreme or like Dunkin' Donuts, you get a free donut.
Really? All right, we got two Bavarian creams and what? You said old fashioned chocolate glazed?
Yeah, old-fashioned chocolate glaze.
All right. What else have we got? Ladies?
I can't make up my mind after eating more than one.
The nurses are standing over there quietly. They're like, we got too many favorites to name one. Which one? Did you say butternut? I didn't know there was such a thing as butternut. Huh? All right. Nothing wrong with that. I got to try that sometime. Me? My favorite is, well, it's hard to explain. Because if I told you what it is, you're going to go, it's not ones. You got to go back like 30 years. And the 30 years ago ones of these were unreal. Apple fritter.
Oh my God, I love apple fritters.
30 years ago, they were like
I don't even
amazing.
I don't even call that a donut because it doesn't have a hole in it. I call that a pastry, but that's
Oh,
very good.
interesting. So maybe I get a... All right, so you're saying it's not a real donut. It's not a real donut? Do I get another donut pick?
You gotta get another one. Yeah.
Oh, all right, let me think about it because apple fritters always been my favorite. When I went to the donut shop, I always got apple fritters. And bear claws. I love the bear claws, but that's a pastry also, right?
All right, it's a pastry.
Oh, you guys, all right, you're getting technical on me. All right, thank you.
But it's true.
Me? Who? Yeah. All right, our viewers are welcome to... Henry, you probably got a favorite donut, right?
Yes.
Go ahead, Jimmy.
Specifically from Krispy Kreme, their chocolate Yeah, chocolate donut with chocolate glaze on it. It's
Oh yeah,
it's
I know
the
that
best.
one.
Oh my lord.
Those are good.
Rita
All right.
Rita replied, "My mom loved apple fritter, crullers, and Boston cream."
Crullers. All right, crullers are my favorite if I don't get apple fritter and bear claw. Who are we missing? Jordan. Jordan, tell me you got a favorite. 5 minutes. Whipped peanut butter?
With peanut butter with what? Oh wow. Where do you get that? Looks like a Reese's donut.
All right, whipped peanut butter. Where is it? Oh. All right, so you got a donut that's filled with whipped peanut butter cream. Right, Jordan? Nice. All right, peanut butter filled donut. Right. All right, now who has not told us their favorite? What's your favorite over there?
Blueberry donut.
Oh, blueberry. Dang, I love blueberry.
That's a good one. Yeah.
Getting hungry.
Same.
All right, somebody put a donut order in with Grubhub. Call Laura. We need a donut order. Seriously. All this work and no donuts makes Jack a dull boy. All right, folks, we are literally a minute away from being done. So far, everything has gone really well for this patient. I'm just going to pull back a little more, see what we got. Yep, this is the end of the disc right here. You can see all this highly collagenized herniation. All that means is scarred up. It's got a lot of scar tissue in it. Why does it have scar tissue? Because his body's been fighting this thing for years, trying to get rid of it. And all that war and battling going on leads to scar tissue formation. All right, have we shown any of our educational videos?
Yes, we have. We have shown both of them.
All right.
Oh, but we do have a question coming
Let's take
from
it.
Larry, once more on YouTube,
Let's take Larry's question.
asking how recent should the MRI be?
Ideally, Larry, the recentness of the MRI should be a year, but we will make exceptions. For example, we'll do a year and a half, and as long as symptoms have not changed and it's clear cut what the pathology is, I think a year and a half to 2 years being the oldest MRI that I would really consider to review. Okay. You know, most people have had chronic back pain for many years. Their MRIs really don't change that much. Okay. Their MRIs really don't change that much. All right, 30 seconds. Just cleaning up the last of this herniation. This actually turned out to be worse than I expected based on the MRI. You could not really tell the extent of damage to this disc or the others that we fixed based on the MRI scan. It did not appear to be as bad as what we're seeing internally now that we're inside. So clearly he needed this. He had 10 out of 10, 10 out of 10, and 11 out of 10 pain. And I think we did the right thing helping him. He's going to go home and he's going to be without this pain anymore. He's going to be a happy man and enjoy the rest of his life. And he's got to give it a year to heal. Everybody needs to give their disc a year to heal. But now that we've cleaned out all the junk, this thing should heal beautifully. All right. We're pretty much done. You got irrigation ready? Any other questions, Henry?
At this moment, no current questions.
All right, well, we're done. Thanks for joining us. Let me show you the size of the incision. We lost probably, I don't know. Let me have irrigation. How many cc's of blood? Maybe 1 cc, 1 or 2. Man, that's so tight. Something's bent. Either the dilator or the tube. Let's get it figured out. Alright, you know how to do that? Test the dilator with multiple tubes and test the tube with multiple dilators and see which one is the problem. Alright guys, here's the incision. Quite literally 7 millimeters. I'm going to put 2 staples just to hold it together tonight. We'll change out for a steri-strip. You guys see that?
Yes, we do.
Go ahead. Alright. Any questions?
No current questions.
Well, thanks for joining us today. We'll see you next week on Tuesday. I got it. You done? I mean,
No,